Hello, everyone, and welcome. Thank you for joining us for the NeHC University program today on consumer engagement in behavioral health, featuring a case study on the Centerstone project. This is Kate Berry, CEO of National eHealth Collaborative, or NeHC. NeHC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and healthcare, including providing education on health IT. Today, we are very pleased to welcome three speakers: Linda Grove-Paul with the Centerstone Project, Doug Dormer with White Pine Systems, and Mike Lardiere with the National Council for Behavioral Health Care. I'll be introducing our speakers in just a few moments. Next slide, please. First, I'd like to highlight a few of our upcoming NeHC University programs. We do have an advisory council who helps shape our curriculum, service faculty, help us recruit faculty, and provide additional advice to us. You can see by this list that our advisory council has representation from virtually every aspect of healthcare and is a fantastic group of people with diverse perspectives and expertise. We really value their participation in our extended team. Next slide, please. NeHC offers a wide variety of education programs, including Spotlight Learning Series on Health Information Exchange, Consumer Engagement, and the Beacon Communities, programs on careers in health IT, a lot of the different ONC programs and initiatives, and trends in health IT innovation. Next slide, please. Very recently, in fact, officially just today, ONC released a request for information on governance of the Nationwide Health Information Network. NeHC will be convening an education program entitled Building the Proposed Rule, an Overview of the Governance RFI. This program will provide an overview of what's in the RFI. Our speaker will be Stephen Posnack, Director of the Federal Policy Division of ONC. And this program is scheduled for Thursday of this week, May 17th, at 11:30 to 12:30 Eastern Time. Next slide, please. On Wednesday, May 23rd, next week, NeHC University will offer the next program in our Spotlight Learning Series on consumer engagement in health IT. This program is entitled The Community as a Learning System for Health, Using Local Data to Improve Local Health. The program will summarize a report of the National Committee on Vital Health Statistics. The report is a product of a year-long NCVHS Community Health Information Project, which examined how communities can become learning systems and what resources exist and are needed to help them. To discuss the findings of this report and subsequent work for this education session, we'll have with us Dr. Larry Green from the University of Colorado in Denver, Dr. Justine Carr, who chairs NCVHS, and Linda Kloss, formerly with AHIMA and now a consultant heading up her own company, Strategic Advisors. Next slide, please. The next program of our Spotlight Learning Series on the Beacon Communities will also be next week on May 24th at 1 p.m. to 2:30 Eastern Time. And this program will provide an in-depth or a couple of in-depth case studies on the Beacon communities in both San Diego and Utah. Next slide, please. You can download the slides from today's program at the URL on your screen, and I believe the link is also posted in the chat room. Next slide. And during the webinar today, during the presentation, please do submit your questions as we go along when they come to mind, and all you need to do is enter them into the Q&A window at the bottom right-hand side of your screen. And now I'm very pleased to introduce our speakers for today. First up, we will have Linda Grove-Paul. Linda serves as Director of Addiction and Forensic Services at Centerstone. Centerstone is the nation's largest nonprofit provider of community-based behavioral health care. She oversees addiction treatment and support services for families and individuals in 17 Indiana counties. Linda manages all aspects of staffing and programming in Centerstone's southeastern county clinics. She provides clinical supervision of therapists, oversees evidence-based program development and the implementation of consistent, fully integrated treatment for addictions and mental health. Linda led the creation of a substance and family education task force, which identifies and treats substance-using pregnant women and developed an assessment program for county jail offenders that allowed them immediate entry into treatment upon their discharge. Linda is also co-chair of the Indiana Association of Substance Abuse Providers, working to promote substance abuse prevention and treatment programs in Indiana and express common concerns to public policymakers and payers of substance abuse and addictions. Then we'll have Doug Dormer. Doug is founder and CEO of White Pine Systems, a leading provider of internet-based interoperable personal health applications and patient engagement solutions. The child of 2 blind parents, Doug has been involved in the independent living movement all of his life, even before it was called an independent living movement. A graduate of the University of Michigan, Doug began his career as a certified public accountant with Coopers & Lybrand. While there, Doug co-authored a book on healthcare reform designed to help hospitals become more efficient. Between 1991 and 2002, Doug served in management positions with Bottom Line Technologies, a global provider of secure financial systems for the financial, healthcare, and manufacturing industries. And more recently, Doug has served in senior management positions in publicly traded and startup companies dealing with IT security and emergency response. And finally, we'll have Mike Lardiere. And Mike is Vice President of Health IT and Strategic Development for the National Council for Community Behavioral Healthcare. Mike has over 30 years of healthcare experience in inpatient, outpatient, and managed care settings, and was Behavioral Health Administrator for one of the largest federally qualified community health centers in the country. He has extensive experience in implementing electronic health record and other health IT initiatives and in integrating behavioral health and primary care. His managed care expertise includes senior positions in clinical and provider relations, where he was responsible for provider contracting, profiling, and quality for over 20,000 clinicians and 5,000 facilities in the Northeast. Mike is a member of the Behavioral Health Work Group of the Certification Commission for Health IT, also known as CCHIT. And I'm also happy to mention that Mike is a member of the National eHealth Collaborative Board. So at this point, I'm going to turn the presentation over to Linda, who will be followed by Doug, and finally Mike, and then we'll open it up for Q&A. So Linda?
Great. Thank you so much. Well, I just want to start by saying I'm really excited and honored to be here and presenting to this group, and particularly presenting about substance use disorder. I think it is definitely one of the greatest expenses to our country, and certainly we have a lot of folks who have a lot of needs, so it couldn't be more important or I think add more value to what we can do, particularly with healthcare reform. Next slide. So today we're just going to go over kind of who we are, definition of kind of what the problem is, introduce recovery-oriented systems of care, and we're going to really be talking about some pretty basic information for those of you who are in the behavioral health world and the substance use world in terms of overview. And so many of the concepts you're going to be familiar with. The concepts aren't new, but it's really much more about the application and patient engagement. Next slide, please. Who we are, Kate did a good job of doing an introduction. I do want to mention I work for Centerstone of Indiana. There's Centerstone of Indiana, Centerstone of Tennessee, and Centerstone of America, as well as Centerstone Research Institute. And Centerstone Research Institute has analytics, health IT, technology, research, program evaluation, and support for clinical programming and development. And that partnership really allows us to bring a level of quality services to our consumers that we wouldn't be able to bring otherwise. Next slide. So the problem, or why change to ROSC? Again, as many of you likely know, the national need for addiction treatment exceeds capacity, and that trend is expected to continue. Only 1 of 10 individuals who need addictions or substance use treatment receive it. We know that up to 80% of the individuals that are in the criminal justice system suffer from a substance use disorder. Further, we know that the complexities of their services add to the funding challenges. And we know that both state and federal governments are in situations where they're cutting their budgets, and that isn't likely to change. Also, we're real aware that people with addictions are much more likely to be poor and uninsured. And frankly, in the state of Indiana, it's almost 90% of the people that we see are indigent and have no insurance, no way to pay for care. So primarily, we have been able to provide services to the people that we have in Indiana through the block grant fund. So we know as healthcare is changing, there's going to be some pretty significant changes in terms of resources that are available. Also, we know that people with addictions have very complex treatment needs. Organizations that are treating addictions are often very siloed, and that most of the resources for people who are suffering with substance use disorder is on the back end. Shows up in the emergency room, shows up in the jails, police, prison, so most of the dollars that go for addictions are not going in terms of prevention or early intervention. It is much more so on the back end. Next slide, please. So if we know that addiction is a chronic illness, which we do, and it's great that we're here with a broad crowd of individuals that certainly understands that, kind of looking at why do we, and again, for those of you who are in the field, you've certainly seen these slides before, but why do we treat it differently than other chronic illnesses? And really, as we look at this, I think we begin to really understand that we kind of need to throw out the framework that we've been using, and certainly SAMHSA has been a leader in this in the last several years. But we need to come up with a conceptual framework to create something better, something that actually fits in terms of what we know about addiction as a chronic, recurring, relapsing illness. So then the question really becomes, how do we do more and more what we're doing more effectively with less resources? So we have to really use the resources that are already there and really think about changing the model. Next slide, please. So here's what we know about need for treatment. And again, we're talking addictions treatment, but obviously in terms of behavioral health, it really could be any kind of treatment. Is basically at the core, you see the treatment plan, but the individual is really the person who's there. Again, the federal government, I think, has really taken a wonderful leadership path in terms of recognizing that not only have we been siloed in terms of how we're providing behavioral health treatment like addiction and mental health treatment, but the need for integrated treatment, that a person is a whole person who has physical and mental health needs. So really the need is for comprehensive treatment. So whole health is really the focus. The other thing is remembering it's very hard to engage individuals in treatment when they're worried about child care, or they're worried about their family, or they're worried about their housing, or they can't get a job. Next slide, please. And this is just a demonstration that really looks at sort of how we are currently organized. And as a provider, it's very clear that we have all of these silos, and of course these silos were really created to attempt to take care of people in certain that have certain issues. But you think about a person who comes out of DOC, and I don't know, do I have control of the pointer, or do you have that, Matt? Okay, yeah, I see. But basically, people who come into the system, oftentimes we're asking them to navigate something that's really siloed and complex. So think about a person who just gets out of prison. They walk out of prison and they don't have a place to stay. first thing they do is they meet with perhaps their community corrections caseworker, and they say, okay, well, we're going to put you on house arrest, so you need to get a job, and you need to have a house, and you have to have a home phone, and you need to show up for treatment, and treatment's going to require you to go to IOP or whatever treatment they require, as well as perhaps 12-step meetings, and oh yes, your child's involved in DCS, and on and on and on. And again, if you really think about it just in a conceptual framework, that's really what we're asking our consumers to navigate systems that are incredibly complex. And as Kate said initially, I work in 18 different counties, so I know in each of these counties and each of these communities, these systems are all really complex and they're very different. But frankly, we're asking our clients to navigate a system that any of us would have a difficult time navigating. And I think really recognizing that the CMHCs and the addiction treatment providers also fall in a silo, and we've been really guilty of asking people to go out and do things that we couldn't or wouldn't be able to do ourselves. So what ROSC really does is says, let's really flatline that. Let's take some of our resources and take them out to the community and bring the community to them and begin to say, how do we navigate, really creating, very much like the healthcare navigator model, so that we are able to bring jobs and employment and opportunities to our clients. Next slide, please. So really looking at what is this recovery-oriented system of care, and I want to just tell you a little bit about how we really came to changing our model. It's been about 2 years, but about 2.5 years ago probably, the state of Indiana announced that some changes were going to be made with Medicaid and services that they were going to pay for and services that they weren't going to be able to pay for, which wasn't unique to Indiana. It's definitely been across the board in other states as well. But I realized that I work for a program where almost all of my clients are indigent, and we're pretty heavily subsidized. And we're in a not-for-profit that is, I think, extremely conscientious in terms of trying to deliver, the best services that they can to the most individuals. But I knew that these cuts that are coming down the pike were very much going to affect the clients that we were serving in our programming really across the center. But definitely looking at our programming in Bloomington, where we had a program that was called the Recovery House. It's a 15-bed co-ed facility for people who just couldn't get clean and sober. And in addition to that co-ed facility, we also had a partial program. So, we were basically during the day having people sit in 40 hours a week of programming, and then on the weekends, they would basically continue to do that. So we were spending a lot of money, a whole lot of resources on people very early on in treatment. And I had the good fortune, and I don't know if Diana Williams is on this call, but the good fortune for our Deputy Director of Mental Health and Addictions actually invited 4 providers to go with her to a SAMHSA business practice conference. And again, that was probably about 3 years ago, and I was able to really hear from the feds in terms of the direction that they were going, and recognizing that the resources that have been there aren't going to be there, and we need to really start thinking about new and innovative ways to work. And so that's really what I came back to Indiana with, and truly in a panic, saying if we don't do something, we know that we're probably only getting in 1 in 10 of the people that actually need our services, and the people who show up on our doors are really desperate. So we've got to be able to figure out how do we do more with less resources and do a better job, because we really weren't doing as good of a job as we thought we could be doing. So in partnership with the division, they arranged for me to have some phone calls with our local ATTC, GLATC, and they arranged 3 or 4 phone calls for me with experts throughout the country, just an hour phone call, but basically started to really come up with some ideas and some thoughts in terms of what we might be able to do. So this is really kind of the synopsis of that. And we also really realized that if we didn't come up with a model, kind of in the state, that a model was going to be given to us, and it was probably just going to be, cuts in funding. So we wanted to propose something that we thought would be better and something that would work for our consumers and our clientele. Next slide, please. So a large part of the focus really is recognizing that a lot of the people who come through our doors are really lacking in recovery capital. And recovery capital, oftentimes I describe as it's kind of all I ever needed to know. I learned in kindergarten. But it's really, it's not rehabilitation, it's that habilitation. There's a lot of our clients that come to us, and they come to us again and again and again, not so much because they have a mental health or substance abuse treatment need, but more because they're lacking in the capital, whether it's to get a house, food, transportation, problems in relationships, problems with their family, access to community resources, but really that we needed to start focusing on. The ROSC literature has a lot of great information on the building of recovery capital. Next slide, please. So really looking at developing this 4-quadrant model where on the bottom axis you have recovery capital and really assessing the clients that are coming in, and then on the vertical axis the treatment need. And here's where really cost savings, we began to recognize that a lot of people who are coming into our treatment center and our walk-in hours are people who maybe did just get out of jail. And the first thing that they're thinking about is, oh my goodness, I really need a house. I need a place to stay tonight, or I don't have a job and I am going to be on house arrest and I'm going to get violated. So really trying to distinguish who are the people that actually belong in treatment, that have the clinical treatment need, versus the people who need to build that recovery capital. Next slide, please. And so here you have a chance to really just look at kind of what is the traditional system versus the recovery-oriented system. I think this is pretty self-explanatory. I think the key pieces really are, though, that we needed to move from expecting the client to be treatment ready to really working with them and having them own their plan and own their care, which is really consistent with all of the literature and literature around motivational interviewing. And also cost-effective recognition that we can utilize volunteers and peers to really help in a lot of the development of the recovery capital. The other piece that I think is really important is that the responsibility is placed on the service milieu and really the lack of recovery capital. So what is it? So instead of seeing a client who's been in IOP, which is intensive outpatient programming, a pretty typical treatment as usual for substance dependence, putting them back in because they've relapsed yet again, and then kicking them out perhaps because they've used. It's really a recognition that the care plan that we have isn't currently working. And again, in large part it's because of capacity that we've done that. And the other piece I want to mention is just that the traditional addictions care, in many ways that model I think was really built around the criminal justice population as opposed to population as a whole. So you have court-mandated population who can be forced into care. Next slide, please. And so the key really is that hope-based motivation. And if you look at sort of the plan and what we're going to be talking about today and what we've developed, you'll see in the middle is the recovery capital scale. And that's really just their assessment of how they're doing in each of their life domains. And when we talk about this, we're really talking about whole health. So recovery capital is, to me, a very generic term. We're talking about substance recovery, but it's definitely something that, you could really be looking at for anyone. And I think the recovery capital scale is really owned by the client. They're the ones who are really defining what it is that they need, and that informs their recovery plan. And from their recovery plan, they're identifying what are their top 3 goals, not mine as the clinician, which, of course, gives personal accountability. They're working with the recovery coach, community resources, and then they have a weekly update that, again, informs the recovery plan and the top 3 goals, but that this really is owned by the client. Next slide, please. And then here's a picture of our Recovery Engagement Center. So this was the 15-bed facility I was talking about before. And again, if you think about, what we were doing is we were spending probably about $350,000 a year to operate that program, which is the housing residential program, but it also had a partial program that went with it, where we had 3 staff members who were working full-time in the partial program, and we said, let's nix that and take those 3 and make them into recovery coaches. And we had some pretty significant turnover in that time, because it really was turning our model of the way we worked on its head and strategically aligning with the community and saying, we want this to be a low-barrier hub for recovery. We want anybody to be able to just walk in the door and be given a warm welcome. They don't have to be a client, but maybe they say, gosh, I just got out of jail today. Actually, judges typically will just send them over, say, yep, if anything you need, clothes, housing, whatever, you can go over there and somebody will be there to help you. So we really have staffed it with volunteers and with the recovering community. And I think one of the things that's really important for us to recognize is that our key partners really in this, my key partners have been the criminal justice community and the 12-step community, because when you're really looking for volunteers and you're looking for resources, folks in the 12-step community are really ones that have to buy in, because you want to have that support there, and also non-traditional resources. So we didn't want it just to be 12-step. We want it to be faith-based groups. We want, basically anybody who wants to support recovery and sobriety to be able to come and join up with us. And then the key really in terms of the criminal justice is we couldn't say we were just going to have a drop-in center for a bunch of alcoholics and addicts. And in fact, if you can't see in the picture, but on the right-hand side, on the other side of the street, is an elementary school. So, we really had to assure the community that, we were taking this very seriously and that we were going to have professional staff that were really supervising. But their job was just to focus on recovery capital and supporting the volunteers and getting up and running, but really transitioning out of responsibility. So as you can see now, we've really gone from a place where we're only able to house and serve 120 patients a year to, in our first year, serve over 4,200 individuals. Next slide, please. So here's just some examples of increased community engagement. Really had to spend a lot of time just going and kind of selling this concept to the community leaders. Really needed to get buy-in from the community leaders, judges, chief probation officers, certainly the hospital. We created an advisory board around one of our grants that we had that had consumers as well, that just said, we're going to make this switch. How do we do this? And then things just began to organically evolve. Volunteers came up and said, gosh, we want to start having some meetings here. Gosh, we want to hold our art classes here. We want to be able to have, volunteer parties. We've had baby showers. And it is really a family recovery center. It's amazing, and it's amazing the activities that are happening. Next slide, please. And so, our main goal really, and we're only 18 months in this, we opened in August of 2010, is really to create a community of care and hope. I mean, it really is the SAMHSA strategic initiatives or priorities in terms of home, health, community, and purpose. And, that's the thing that's been so exciting is from day one when we opened the doors and people saw that there were people sitting behind that desk and volunteering, you had people in their first day of sobriety say, I want to be able to do that. Well, in order to do that, we have a 3-tier volunteer system. You're going to have to, be clean and sober for 6 months and good standing with your probation officer, but there's still other things that you can do. You can help us for an event. What do we need to do to get you engaged? But it really was creating a community of care and hope, and that community has so many things have evolved from it that, I haven't been involved with or touched, or, even our staff have. And I think that's actually the other thing that's really important to note is at the Engagement Center, we were really careful not to sort of brand it as Centerstone. We make it a community engagement center, so it really feels like it is part of the community. But because we're really in a relatively, it's in Bloomington, Indiana, and that's the most urban of any of the areas that I supervise. They're all very rural, with just volunteers alone, unlike major urban areas like Philadelphia and some of these places where they're able to get these volunteer-only services up and running and maintaining. It's very difficult to find enough volunteers that have enough traction as we're going forward. So, and then I think the other piece that's really important is really creating a business model. So we were able to really demonstrate not only could we serve more people and serve more people more effectively, but we were also able to sort of sort some of the people out that don't belong in the clinic and don't necessarily want to be in the clinic, but we can target specifically what their recovery capital needs are, and have consumers that are much more invested in their plan. As you can see, Project CARE, which is an offender reentry grant that we have, and has been a huge partner with the Recovery Engagement Center, and use this coaching model. We've decreased recidivism by about 50% for that program. So very exciting there. The Recovery Engagement Center was awarded the MHAI Heroes in the Fight Award. We got the Key Consumer Agency of the Year Award for 2012, and one of our volunteers got the Key Consumer Volunteer of the Year, and so that's a statewide award. Next slide, please. So what are the limitations to the current model that we have? Obviously, geographical transportation barriers. Physically, if you can't make it to the building, you're going to be limited in terms of how much support you get, and oftentimes the clients lack the resources. And if we go back to the Capitol, it's not just the physical resources, but sometimes it's the motivation, the internal capital and resources, just that fear of showing up. Some clients need really basic supports to get there. And so we really began to start thinking about, what is the next step? How could we engage? And last year I went to Nashville, Tennessee to do a presentation on the Recovery Engagement Center to Centerstone Research Institute staff at their all-staff meeting. And after I had done the presentation, one of the people who was there had seen the Health IT grant come out and said, oh my gosh, this would be so great. We could basically create this exact same concept through Health IT. So we really said, you're absolutely right. We think this is really the next step. How do we engage more people, and particularly the people who are having the harder time engaging, the ones that are falling through the cracks? And that's typically what the focus of this really is on. The folks who need recovery engagement are the ones that are not engaging, not retaining in treatment, the ones that the coaches go out and look for. And so I think, we're just a very cursory knowledge of kind of what the coaches do and how it really works, but they really are community-based, going out and meeting the client rather than expecting the client to meet them. Next slide, please. So what we really want to do is expand participation beyond our current facility, but how? Who do we want to engage? We want to engage people who are entering recovery programs, people who are completing recovery programs as they return to the community, and I said or not, because sometimes it's not recovery programs, maybe it's prison, people who are coming out into the community but they're transitioning back in, people who are at high risk, people who haven't had access for whatever reason, whether it's transportation, whether it's technology, whether it's fear, shame, stigma, and people who haven't been successful at other programs. Next slide. And so the answer was this eROSC, and as I mentioned, we had some inspiration when we presented at CRI, really blending sort of that technology with what the clinicians are doing and saying, how can we make this into the next step? And I think that, that's part of the reason why I'm so excited to be presenting today is it really feels like for the first time, not only is behavioral health on the radar screen, but substance use is on the radar screen. And there is no social problem that costs our nation more than substance use disorders. So I think if we really are, honest with ourselves, there's probably nothing that's going to save us more money in the long run than investing in resources and the technology to provide better and more accessible treatment to our clientele. So this was really our opportunity. I feel so honored that we were awarded one of the SAMHSA Health IT grants. And I know on our first conference call, Dr. Wesley Clark was on the call and said, basically, Congress appropriated some funds for us to go out and to try to, make a model, demo a model, and see if it could be something that, we can use. And that's really the way we were thinking about it when we wrote it, and definitely the way we're thinking about it as we're implementing it, is that this is something that has, implications for the small population that we're looking at right now, but we've really worked on this so that it has, that it can be used not only for substance use, but for other issues as well, and not just for the people who are in this program, but people throughout Centerstone and hopefully throughout the country. Next slide, please. And so here are what we're looking for the key outcomes, and that's the other thing that's really exciting about technology is obviously it's much easier with the information that we're collecting and collecting the information electronically to have outcomes. And we're very, we were just awarded this grant in September, just entering our first patients into the program at this point, really working on the technology at this point. But these are not outcomes that we have a whole lot of information on, but these are definitely the ones that we are planning on tracking. Next slide, please. And I am going to transfer it over now to Doug Dormer.
Thank you, Linda, and thank you all for joining us today. My job is to introduce you to what we call the Substance Abuse Care Unit, which is the extension of the ROSC program, the Recovery-Oriented System of Care, through this stack of technologies. And as you can see here, it begins really with very public social media sites, as well as then moving to our own hosted, moderated discussion, live chat, resources, moving from there to a personal health record, in this case called a personal recovery health record, through to some very specific recovery tools, and ultimately linked in and tied to the electronic health record. It's significant, for example, that in Second Life, we understand that the largest domain within Second Life is health care related, and within that, the second largest cohort is a self-organizing group around substance abuse. So we look at this not as a traditional patient portal, perhaps might, or even a personal health record, but we overlay it with elements that we think of as public health IT, so that we are trying to use this technology to address within the particular community. How do we engage and overcome barriers to care utilization appropriate to that community? So the configuration, the combination, the emphasis for Bloomington might be quite different than, say, Denver or Tucson as an example. Now, the term care unit is something we've used for several years. We've been working with Indiana Purdue University under Dr. Josette Jones, the Graduate School of Health Informatics, for the last 6 semesters. We've had teams of graduate students work with us to use a model we've been refining over time to understand the express requirements that are necessary to achieve high adoption, initial adoption, high persistence, high value for all stakeholders along the way. In this case, with the ROSC program, the technology focuses principally on these 3 middle areas, but overall, the care unit analysis and approach deals with the full range of solutions. Next slide, please. It helps if we think of this as 3 logical domains. The first domain is really the public segment, including a heavy focus on resources, so we can sort by county, we can manage and allow people to participate with events. You'll see this in just a moment. I will say that we include the moderated discussion and the live chat in those, along with request and appointment, but all of that we think of as the public layer. Within the private site, we have two sets, really, two domains. One is the recovery tools, and the last of the three domains is the personal health record. Each of these then represents a different need. Now, all of these are clearly covered by, or in some fashion, by, for example, HIPAA broadly, and then when it comes to substance abuse specifically, we certainly have to address 42 CFR Part 2. The way in which these are configured and the impact of those rules on how these domains behave does vary given the inherent differences between the domains. We don't have time today to go through all of that, but it's a fascinating exercise that is indeed evolving. But I would think the important takeaway is that today there is no reason not to engage in this kind of integrated approach to all this, to this kind of patient engagement. I should also mention that these are interchangeable modules, so that, for example, the substance abuse public site that you'll see momentarily could easily be exchanged, and we're in discussions with our friends at Centerstone about how to extend it to another affiliate of Centerstone, an excellent site called notalone.com for returning veterans. What a wonderful way to bring in different forms of social media that are at different stages of development within the community. Similarly, the recovery tools really is the domain for the clinical set of tools. They may be a different set for PTSD or depression or for other behavioral health or physical health domains. And of course, the personal health record really becomes the avenue by which the individual can coordinate and serve both for care coordination and patient engagement between behavioral health and physical health. And we'll look at a couple of examples of that, one at least in a moment. Next slide, please. I think it helps to have this, I can't say architectural drawing, but this overview of how things fit together. Centerstone, of course, on the left is both the organization and that public site. The recovery tools we host on behalf of Centerstone, so those are really subject to a traditional HIPAA business associate agreement that would be we host, and they are a part of the clinical record, the tools that you'll be seeing. Conversely, the personal health record is branded as Centerstone. Centerstone may have access to it, but the data, the information, is truly controlled by the individual. And we work closely with Microsoft Health Vault. We were one of the earliest Microsoft Health Vault partners, which allows us to leverage and contribute to and get value from that extended Health Vault community. Now, through us or through Health Vault, different ways, different configurations, we then participate within the broader community through, let's go back please, within the Health Information Exchange. We support the DIRECT project, and something I'm very pleased to announce here, it's kind of an informal announcement. There will be something formal, I think, a little later on. Our friends at Centerstone have agreed to participate in a project that is being sponsored by HL7. I serve on the a couple of HL7 committees around personal health information, one of which is a CCD, Continuity of Care Document to Blue Button Transform project. So we will be, in the next versions of this, as we roll this out, people will be able to export from their own personal health record or to exchange data following the CCD for machine-to-machine kinds of transfers, but also using the HL7 CCD to Blue Button Transform to be able to download using the Blue Button protocol, which is consistent then with what we see from the VA and CMS and increasingly from other state organizations, and also now under a December rule for all federal employees. So we see tremendous opportunity right now, tremendous opportunity not only to extend the physical rec center that you saw earlier, but also to engage new people who have been on the periphery, who have been reluctant or not had access to that kind of a facility, and then further to see the integration between behavioral health and physical health. Again, looking back, SAMHSA just recently published an excellent document summarizing the correlation between substance abuse and diabetes, hypertension, COPD, We certainly also see it and are working on another community where high rates of negative pregnancy outcomes are correlated with substance abuse, and also, of course, hepatitis C. So we see a tremendous opportunity using the same infrastructure. And with that, let me pass it back to Linda. And thank you all.
Thank you, Doug. Yeah, next slide, please. So here's the landing page, and this is a screenshot, but if you do v-recover.com, you'll actually get to the live site. And this really is like walking into the living room of the Yellow House, and that's really the way we've tried to create this page. We want it to be accessible. Basically, anybody can get a log on. We're watching it to make sure, if anybody posts something inappropriate, we can pull that. But if you can see on the left-hand side, trying to keep it current, we have news, bulletins, what are the things that are the latest. In the center is a discussion. So that's a discussion board that is active. People are coming in. What are you doing today? Whether it's inspirational quotes, but they're really able to communicate with one another. And then along the top, you can see the other resources that we do have available. One of the most significant is the calendar, which is in the middle. And if you look on the right-hand side, if you scroll down that page, which you can't because we just have a screenshot, but if you go look at it, you'll basically see what are all the activities that are happening at the Recovery Engagement Center on a week or on a daily basis. So somebody says, oh, Veterans in Recovery meeting is happening. But it really is making it accessible. And then there's the resource tab, which basically is a living, breathing document. We're saying, tell us what the resources are. And again, electronically doing something that we're going to get, we think, much more value than we could just with the physical location. Also, at the top right-hand side, you see the request an appointment. You hit that box, it'll open up, and then it'll basically say, if you're in one of these 5 counties and you have a substance abuse problem, request an appointment. So it lets them know, sort of what are the parameters at this point of the grant, as well as on the bottom right-hand side, leave a message. And if somebody was on, it would say, talk to me now. And Julie, one of our coaches, oftentimes is logged on, and so the person has the ability to talk to them live. Next slide, please. And there's a lot of other cool things that there's no way we're going to get to because I know I have to hurry up. So as we look at the recovery support tools, I think this is an important slide because conceptually when we actually go from that public side into the PHR, when we're really working individually with the client. So we've identified somebody who wants to work with us, somebody who has had trouble, they've fallen through the cracks, and we're saying, this is an individual we want to have participate with our recovery coaching, whether it's with the grant or not. We have basically electronically built the recovery capital scale where they go in, they complete that on the left-hand side, that auto-populates their recovery plan, and then they determine which are their 3 priority goals. So, they may say, oh, there's 7 goals that should be priority, but the individual is really saying, these are the things that matter to me and the things that I want to focus on. So we go from those 3 priority goals down to the TMAC, which is their weekly update that really looks at the risk versus protective factors, what their goals are, what kind of work they've made, and any kind of future work or modifications they want to make. Next slide, please. I don't know why. That's ridiculous. Oh, my timer's done. So this is a landing page for the clients. So this is somebody who actually has become a patient in the EROSC. And so they're drilling down into that next layer that Doug was talking about. And you can see a few things that are different on this. The calendar that's no longer the Recovery Engagement Center's calendar, that's their personal calendar. And their personal calendar is going to be loaded with the things that they need to be doing. Maybe they have a probation appointment, maybe they just got a job, or they're going for an interview, maybe the coaching appointment is something that they have there. And that is going to function with text reminders, but we really want to make sure that these pieces are basically, the technology is really integrated into how a person is living their life. On the left-hand side, that arrow that you see, we'll talk about that more in a minute, but that's really the difference when they're doing their weekly update. That is the difference between their risk factors and their protective factors. So that's their TMAC net score. So it's green, which is positive, and it's a 4, so it's a plus positive 4 for the week. And then you see their 3 priorities. So those are the goals that they have made on the recovery plan, and how they're rating themselves in terms of how they've been doing over the last week. Next slide. So then on the left, you see those are the recovery tools that Doug already pointed out, that are used by the client and the coach to plan, organize, and direct the recovery supports. And this is part of their clinical record, but it's also a part that they are able to update. So their weekly update is completed by them, not by us. Next slide, please. The other part is this is really the Microsoft Health Vault sitting on top of this, and the client is able to have access to their record. As Doug indicated before, we really are trying to integrate learning from other grantees that are doing the integrated health, and making sure that all of the people that we're enrolling in this program, that we are capturing all of the health indicators, that we've had our staff trained to make sure that they're screening for diabetes, that we're doing blood pressure checks, weight checks, those kinds of things, because we really want people to be invested in their whole health. That's critically important to this population who, as Doug said, are at high risk for lots of significant issues. The other thing up at the top I hadn't mentioned is a message center on the right-hand side that says they have 3 new messages. And this is a chat feature that they have between the patient and the coach, so they can kind of send messages to one another, and then if the patients give permission, they can talk to one another as well. Next slide, please. So then this just gives you an idea of what the recovery capital scale looks like. So this is what the client is going to be filling out at the first session that will inform their recovery plan. As you can see, it's Likert, pretty simple, pretty straightforward, easy to fill out. Next slide, please. Here's their recovery plan. So the recovery plan is going to be developed from them completing the recovery capital scale. And then the client is going to say, okay, here are what my top, from the recovery plan, here are what my top 3 goals are. And so then the coach and the client are going to work together. The client has identified that their top 2 goals are to stay clean and find a job. So there are the objectives that they have identified, and that's what the progress measures are going to be. Next slide, please. This is the weekly update. So this is the client's view of what they have to fill out on a weekly basis. As you can see, it's real straightforward, really easy for them to complete. It's just a radio button or a number. And then once they complete that, next slide, please. This actually, it wasn't the next slide. Could you go to the next slide after this one, please? One more. Once they complete that, then this is a screenshot that basically shows what the coach will be able to see. So if I'm the coach, I'm Julie, and I know that I have my 4 clients that are coming in on Monday, I can see who all has completed their TMAC. So you see in the middle status of TMAC, it says 2 or unfinished. So I can just give them a call and say, hey, what's up? You haven't finished it? Or they may say, oh, I don't have a computer, or my computer's down, or I wasn't able to get to it. Let's just go ahead and do it over the phone. And also you can see that she can see what were their last 3 scores, what was the net of the last 3 scores that they viewed. So how are they doing just generally, so it gives them context. If you could go back to the previous slide. And then this shows kind of where that radio button or the arrow came from. So we're really measuring the difference between the risk and the protective factors. But you can see that there are a lot of, that comes from a number of different measurements. 2 slides up now. And then this is the landing page for Julie to actually score the TMAC. So after they've done their weekly session, whether it's been in person or over the phone, then the coach is able to look at it, score it, talk to the client about it. They may see that there's a discrepancy between, kind of what they think they've been doing or what's been going on and what the client, but it allows them to really have a conversation. And as you can see, if you go back to, thinking about the previous slide, it really is very much client-driven. It's giving them all of the tools that they need in a very cognitive behavioral therapy way to run their own recovery and to know what are the next steps they need to take. Next slide, please. And as Doug said, this is an example of a diabetes slide, but the point here is their landing page can be personalized. And as he mentioned, we're really looking at this as an integrated health model. We don't want to just look at their substance issue because we know a person is a person, a whole individual who has lots of needs. And if we're going to be attending to their substance use, we need to really be attending to their whole life. And so the medical part is going to be just as important. And we want them to feel in control. We want them to be able to see and feel a sense of progress. Next slide, please. And so ultimately, our desired outcomes are obviously for people with addictions, abstinence, improved health, wellness, and quality of life. Again, that health, home, purpose, community, really helping people build a community. I think that's part of the reason why actually this is so significant is we're not just trying to do an online community where people are just able to engage anonymously with other people. We want them to be able to engage with real people and know real resources, or hey, we're in rural Indiana, as the 4 counties that surround Bloomington are, and I see that there's 6 other people that are on from Spencer, the same community where I live. Let's get a meeting together. Or we don't have a good dental clinic. What can we do together? But it's really bringing power to the consumers and power to the providers who are providing the resources. So in terms of healthcare providers, improves operational efficiency. We talked about the business plan. We could definitely show some data in terms of the cost savings from this model versus previous models. The EROS PHR components help us meet stage 2 meaningful use requirements and supports new payment models. For payers, you just think about what are all of the options and the opportunities. And obviously for communities, we're not the only stakeholder. We're just really trying to get this process started. But really, ultimately, this is just a powerful tool and resource. Next slide, please. So join us for the grand opening. We are going to have a grand opening of the virtual REC, Virtual Recovery Engagement Center, on June 1st. And if you're interested or want more information, contact Julie, our coach, at that email address. And that is it for me.
Thank you so much, Linda. This is Kate. That was fantastic. Both you and Doug presentation was great. And now we want to give Mike Lardiere a chance to provide some national perspectives as well. Mike?
Thank you, Kate. And thanks, Linda and Doug, and excellent presentation. I'd just like to talk a little bit about how this fits into the national picture. We're working on a survey of behavioral health centers around health information technology adoption and readiness for meaningful use. We did ask questions around having a personal health record, and we had about over 500 respondents to the survey, which is about 28% of our membership. On that survey, though, about 72% of those who responded don't have a PHR available for their clients. And it's also known that about, from those responses, around 66% of those, if they do have a PHR, it's not really connected to their electronic health record or not. So those are some things that are very important as we move forward with PHRs. We did ask some of the questions about barriers to use of the PHR, and the biggest one was computer literacy of the client, and the English language proficiency was the next one. And the other piece was, which was the largest, about 54%, or second largest, about 54% of the respondents, and they could have responded to multiple answers on this one, identified lack of patient or client interest. Now that's surprising compared to what was just presented and what's going on at Centerstone, because they have over 4,200 clients that have opted to use this mechanism. So we may be finding that, clients are not interested if they have to go build it and find it and look for it. However, once it's presented to them and it gives them a opportunity to actually help to engage in their own care and improve in their own care, it's very, very powerful. So I think we'll have to follow that as we move forward to see where these services are available and how clients tap into them. I think the use of peers is very, very important, and that was shown throughout the presentation. The use of community partners and really leveraging other resources really helps significantly. I'm a social worker by background and start out doing case management and other activities around coordinating care, and leveraging the other community resources that a client will touch at the same time that they're in treatment with any particular provider is extremely important in continuing their sobriety in the case of substance abuse, but also in terms of their improved overall health care if you're just looking at a chronic disease. Having worked on the medical side as well with federally qualified health centers for a number of years, these tools, or this tool, or these types of tools, certainly transcend behavioral health. They're excellent types of tools to be used for integrated health services for really any chronic condition. Certainly some of the screens would need to be modified for other chronic conditions, but these are the types of consumer engagement tools that I think will be extremely, extremely helpful going forward. Being participant controlled and having the consumer really identify what they see, who has access to which pieces, is significant, because I think engaging, it's all about engaging people and having them have control of what they're using is an excellent way to engage with them. It gives the organization, the provider, an opportunity to really manage the client across their continuum of care, because with many chronic conditions, medical and behavioral health, people will have spikes in their need for care and be at a higher level of care. 1 week they may have had a disaster in their family or a difficult family situation, and we could see changes there in other chronic conditions as well as substance abuse when those type of life situations happen. So being able to manage a patient, a client across the continuum of care is very important. Having the PHR connected to the electronic health record is also important. There were some studies done a little while ago, I believe from Chicago. They found that when a PHR was actually connected to their provider, patients, clients were more likely to use it, as opposed to it just being a PHR that's hanging out there, not connected. So that's significant as well. The last piece I'd like to address is really the operational efficiencies and return on investment. And there's certainly a cost for implementing a program such as that. However, the return on investment needs to be looked at a couple of different ways, but it's not just a hard savings. If you're familiar with the jail system and people coming out of the jails and into care and going back into the jails and a revolving door, the statistic that they use with their jail transition group to decrease the recidivism rate significantly has a impact on all of our society with people not going back into jail. The other way to look at your return on investment is really around staff time. If clients are using this tool and use this tool in a way that prevents them, it doesn't really prevent them, it gives them tools to use so that they don't escalate into an emergency situation and then either call up the provider in an emergency, which oftentimes in behavioral health you may end up spending 2 or 3 hours with a person in an emergency situation. That can be avoided because of more constant contact and follow-up with the client. You're saving staff time as well, and staff time then generates other opportunities for them to see other paying clients. So when we begin to look at the return on investment in these tools, we need to look beyond just what the dollar amounts are bringing back and look across the board and see how it's saving staff time as well, because that's a significant thing. If you cut down 10% of all the emergencies that your staff deal with, well, one, they'll be happy, and two, it'll give them a lot more available time to spend with other patients who maybe need a higher level of care or more touching at any juncture of their treatment. So those are just some of the thoughts that I had as we went through the presentation, and I think that fits into where we're going nationally. We certainly need to do this more. Meaningful use is going to require that we do have this kind of flexibility with patients. So I think it's really the wave of the future, how we engage consumers in this as well. Certainly fits into a NEHC project around consumer engagement, around health information technology, and having a tool like this is a way to allow consumers to become engaged, and might even be a stepping board for them to engage in this before they even get to using an EHR and having other data through the EHR come back and forth to them. So those are some of my thoughts nationally. I think it's the wave of the future, and the more we engage consumers in these kind of activities and self-care, self-management, supported self-management, they'll be able to maintain themselves much better in the community and not need higher levels of care, which will reduce costs for all of us across the board. So with that, maybe we would want to open up for some Q&A.
That's great. Thank you, Mike. And we do have quite a few questions flowing, and we have maybe almost 20 minutes for Q&A, so I'll just jump right in. And I think this first one, Linda, is really for you, and if we could put Linda's slide 15 up. We had a question, Linda, what are the implications, or what implications does the siloed model pose for sharing information across various different care providers?
Well, I think right now, obviously, there's no question that the siloed model is the model that we're working in right now. And obviously, if you're advocating for a client, you have to have releases of information for any of these people that the coach would be working with a participant on. But I think as Mike was talking about, it really is about breaking down the silos. I mean, a large portion of kind of developing this model and having this be successful is getting buy-in from kind of key leaders in those silos. And that was actually something I wanted to mention is part of the breaking down of the silos really has to do with you've got to get key top leadership in each of those silos to really believe that there are silos and what are some of the things that we need to do for, like with Mike's example, we have so many people who are coming out of prison, back to their home communities, and perhaps those people have even done, participated in a therapeutic community. They've done some therapy, but when they come back, they're not necessarily linked in with a community of care, that transition is really tough. So how do we increase our communication, and then how do we begin to troubleshoot and problem solve what barriers are actually there and how we can make sure that we can exchange information. Right now most of our systems don't talk to one another anyway, so it isn't necessarily about releasing information electronically. It's more about just the traditional releases of information. But if we don't advocate, and that's really where the coach has come in, is the coach can meet with the person the day that they come out. They can help them get to know what are the resources in the community. And so by the coaches going out as opposed to working as partial staff kind of behind our walls and saying, well, you need to go do this and this and this, is they've really become care navigators. They've become experts in terms of where do you need to go, who do you need to talk to. So it's really about developing relationships, and relationships not only on the ground level with the people who are doing the work, but who are the leaders in each of those silos, and how do we get them to buy in to say, wow, this model makes a lot more sense and we want to really be actively involved.
Another one for you, Linda, I think. So the question is Centerstone involved with medication-assisted treatment with methadone? And if so, or like drugs, and if so, how does that work within the model you described?
Yeah, we don't have any methadone clinics in any of the Centerstone counties where we're working. It's not to say that we're only about an hour south of Indianapolis, that there are patients that may be on methadone. And again, we don't get into people's business. I mean, I think what we've really created is an environment that's really safe and respectful of the clients. And so they're really invested in the volunteers and keeping it safe and respectful. And so sometimes people come in and maybe they've only been clean and sober one day, but it's not a question of us making a judgment. It is all about meeting people where they are. And if they're, making an effort and they show up, then we do what we can to support them. And that was, of course, one of the main concerns I think that the criminal justice system had initially, was like, oh, this is going to be, drug dealing. And again, I think people really saw how, we really just gave them this facility and there's a safe place for them to go. And, there's moms that come in with their babies, there's, kids. I mean, it's really an amazing community program that is really invested. The other thing I'll say about that was for Centerstone, this has been a real culture shock for us as well, because we really are doing some things very differently than what we've done previously. And one of the big ones was to say, we're going to kind of create this community center where people are coming and going. And because we're doing a lot of like 12-step and support group meetings in the evening, we said we need to have like a real estate lockbox, a way for folks to be able to come and go. And so we've given that code out to whoever's the chair of, any number of meetings. And we also have a residential facility. So we actually have 6 beds that are available for men who are participating in drug court, because we thought, gosh, we don't want the beds that are upstairs to go to waste, but we just can't supervise the way we did before. So we just have an overnight monitor that's supervising them, and then the rest, they have to be there from 10 o'clock at night until 6 o'clock in the morning. But we don't really have any problems with, even with the lock on the door Nothing has been stolen in a year and a half. You think about all of the people who have, come and gone, sort of all of the stereotypes that people would have about people is this model works. If you're really respectful and you set up a safe environment, that's not to say that there aren't, situations that have happened that, we would prefer not to. But, I think it really is because we're doing it the way we're supposed to be doing it that people really appreciate it and they're getting better. And the other part is so much of the time we don't even meet people. People come in, they walk in, they talk to volunteers, they hook up with somebody who is there for a 12-step meeting that's able to answer their question or, support them. So, we've really managed to kind of have a triage, if you will, factor that doesn't really even include us or any of our staff.
Mike, there's a question for you on the survey results that you sort of highlighted a moment ago. Who was your audience, or who were the respondents to that survey? What was the population?
The respondents we sent out the survey to a little over 1,700 National Council members, which are behavioral health organizations that are both mental health and substance abuse organizations. Many of them providing multiple lines of service. So it was our membership, which we feel is a good representation of behavioral health across the country.
Great, thank you. And I think this next one is for Doug, but maybe Mike and Linda might also want to comment. I'll start with Doug. In your experience with the various tools that you described, what are some of the best practices that you have learned, sort of regarding how to manage or how to protect patient privacy in those different tools? And then a corollary is sort of how, what are the best practices for educating individuals on why to consent for their information to be shared?
Oh, my Lord. Do we have another 3 hours?
Not quite.
That's a tough question. Let me say this. I serve on the HL7 PHR work group that is now a little later this year going to ballot on a standard that will be, I think, the basis for either CCHIT or meaningful use kinds of accreditation. And as we move down that road, we spend an awful lot of time building the PHR functional model PHR system functional model that addresses many of those questions, and I think will provide excellent guidance. Now, with that as a statement within healthcare, I think a lot of this has already been handled. I think we can learn lessons from the financial services industry, an industry I come from, and I think that it's nothing exhausting. There are some significant differences. I'll comment on one that is, I think, important that we as a nation or as a community have not yet fully come to terms with, and that is that the difference between what is needed for security and privacy when we're dealing with someone who's acting in a fiduciary responsibility. I'm speaking here of a provider or a clinician directly or through a business associate agreement, a covered entity, or through a business associate agreement. That relationship is different than the security and privacy obligations with respect to me and my own information. When I'm dealing with my information through a provider, I'm very concerned about what they do with their information. When I have adequate controls over what I can do with it, which doesn't minimize the strength of those controls, my risks may be different. In my own case, as my mother was failing, the risk for me wasn't that someone would know my mother had Alzheimer's disease. The risk was that someone would not know that she had Alzheimer's, if I said that correctly. The risk wasn't that they would find out she had Alzheimer's. The risk was that people would not know she had Alzheimer's disease. And we find that time and time again. So as this notion of security and privacy evolves, it will evolve around security, privacy, and control. So the opportunity is tremendous. The technology is available. The question is policy and understanding. And I firmly believe that the policy writers will lead us where the market takes us, where people indicate over time through their use. Last comment on this, 10 years ago, I was looking at some of the speeches I gave recently, presentations. They were all about how the internet would in fact one day, because this was maybe 12, 15 years ago, the internet would in fact become a means of commerce, because at that time the theory was we would not have the internet for commerce. It was insecure. Identity theft would be a huge problem. You couldn't rely upon it. How would you know the accuracy of the transaction? All valid concerns, all reasonable, and in fact concerns that have been borne out, and yet look at where we are today. I think we're seeing, as Mike said, that same transition in healthcare right now.
Any other comments on that very important topic, Mike or Linda?
No,
I'm good.
Okay,
yeah.
we'll keep rolling because we have a lot of questions. So, and Linda, I think this is for you. So within your program, how does someone with limited financial resources and/or no computer access participate in the EROS?
Well, you know, that's one of the wonderful things, again, about kind of working with an agency that has a real commitment to folks who don't have resources, is obviously we have a limited amount of resources that are available, but, you know, we really are committed to providing services to people who need it the most. So services are always accessible. So they don't have to pay for services, particularly with the coaching. And again, we're really targeting coaching for people who need that level of care, people who would not otherwise engage. So you're really looking at people who have engagement problems. And as far as the EROS is concerned, we did build into the grant some resources for technology for a certain percentage that we estimated would not have technology. We actually did a survey while we were writing the grant to determine how many people had access to smartphone, and I think only 5% of our clientele had access to a smartphone. However, 75% had access to a text-only phone. So we found, okay, yeah, that technology actually is going to be good enough for us to, you know, if we can call, we can follow up, as well as texting, the reminders, those kinds of things, then they could participate, and then we have a fund to support the technology if they don't have access to a text-only phone.
If I might,
oh, go ahead. Go ahead.
I might weigh in on that as well. That's an absolutely critical question. And in our work on this, and in fact it wasn't an accident that we didn't call out in our slides, those few we did put up, anything that focused on the platform. One of the things we are trying to do is make the solutions as platform agnostic as they can be. So it's about the process and the content. So whether it's on a computer or an iPad or a smartphone, the applications should all transfer in a fluid, easy-to-support fashion. Now, the bigger question, as Linda just said, is what is the profile of the community that we're trying to work with, that public health question. And there, we have to really address the lowest common denominator, not as the sole, but as certainly an inclusive approach to the platforms. We are very much focused on using text-based solutions, text-based phones, as one measure of the lowest common denominator. I think the economics of this will bear out over time whether it becomes more cost efficient to say, look, we're going to provide you a cell phone, and we are working with some of the wonderful cell phone companies right now, on this, a smartphone, or perhaps we can strip this down to a cell phone, a text-based phone. But there's always that trade-off between functionality and access and ease of use. And so that's an equation that over the 3 years of this grant we will continue to refine. The one last comment that was significant, in another community in California, migrant farm workers, there was a study where they were given a personal health record. They had language issues, they had citizenship issues, and they had access to technology. They found it, according to the results from that study, to be quite effective as a means, because the people could use it, if nothing else, as their own personal health record as they communicated with providers. And when they needed to have access, they found that they were able to begin to leverage. That by no means is an extension and to say an adequate solution, but it's interesting that the value outweighs the cost for really all stakeholders when you work it through carefully. But you have to go to that lowest common denominator. Thank you.
Very interesting example. A related question, we do have several questions sort of related to the use of social media with this group. So can you explain a little bit more about Facebook and Twitter, a role in the program, and what about is the anonymity of the patient compromised potentially by using social media? and I'll just open it up. I don't know, Linda, do you want to start? Or
yeah,
Doug?
or Doug, I don't know. Doug, you want to take this one?
You know I can't resist.
Yeah.
Let me first mention that on another committee on which I work, the HIMSS Personal Health Information Task Force, I serve on the Behavioral Health Committee and also on the Social Media Committee. Our leader on that committee, Brad Feidel, worked with a number of us to produce a white paper on social media in healthcare. I would urge all of you to do a search and find that on HIMSS. It's about a 30-page excellent document, so that's a great resource on this. When I showed the slide of the 3 domains, a lot of what we're talking about here is hidden in that idea. For example, when people are posting things to the public website on the moderated discussion board, a couple of things. They can put what name they wish to be shown as, number one, and number two, they are certainly aware, they are declared to be aware, we're making them aware, but it should be certainly intuitive that you're posting something to the discussion board, it's public. Now, that sets one expectation for an individual choosing what he says about himself. That doesn't minimize one lick the provider's obligations under 42 CFR Part 2. So when I say there are different implications, that would be a good illustration. It's not a technology barrier that says you can't post this stuff that we're relying upon. It's a procedural, a policy thing that says someone can say what he wants, like he can paper a billboard and put it up there if he wants to, but we can't engage in that kind of discussion. And so social media is becoming a significant part of healthcare already. It's a raging debate. We all see it. But in this case, it's self-organizing with sites like Patients Like Me, with the activity on Facebook. There's a fascinating Twitter group that meets every Sunday night, mostly of professionals, under the hashtag HCSM. And they meet and for 2 hours, or 1 hour, I believe it is, on Sunday nights through Twitter, deal with these kinds of issues. So whether it's providers or whether it's consumers organizing themselves or ultimately consumers dealing with providers, that time has come. We look at the excellent work by the Mayo Clinic. So it's a matter of how will we engage and how can we make it in a sustainable fashion that contributes to the funding models that are available rather than opposing and struggling against it. I hope that's an adequate treatment for the moment.
Yeah, and I just want to mention, you know, kind of like when people started coming to the Recovery Engagement Center, really setting clear expectations that, you know, people are not required to come to the Recovery Engagement Center. And that's one of the things that clients say is, you know, you have no idea who's in the Recovery Engagement Center. I mean, whether people are identifying if they're a consumer or they're a volunteer or they're peer support. I mean, there's no way for people to know or be aware, but they're making that choice, but you want to make sure it's really an informed choice. So we're really careful to discuss that with people, you know, if they are somebody who's a patient and they are coming over. And the same thing is really true with technology, and I think that's one of the things that we've found, and it was in one of the slides, but it is important, I think, to say that oftentimes, and I find myself in that same position as somebody who's not terribly technologically savvy, is not necessarily knowing what the implications are of, you know, oh yeah, use my login as same as my Facebook login, and then it might show up on Facebook. So we're really working with our consumers, our clients, people who are saying, yeah, I'm interested in using the technology, to know how to set privacy and security settings, to really know how to utilize technology, because I think that is really an important piece.
Wonderful. So, you know, we are almost out of time. I'm going to do one last question, but I'm going to suggest our panelists maybe we consider doing a part 2 to this where we just kind of have an open Q&A. But so the last question I'm going to ask all 3 of you to weigh in on. The comment is, this is a fantastic model, fostering very patient-centered healthcare. So what resources can you direct us to so they have things they can use to recommend to their mental health community leaders and partners on how to kind of move things in this direction? Do you each have some thoughts on resources that folks can turn to?
Well, I am more than happy. My email address is there. Folks can feel free to send me an email, and we've written. It's not a published white paper, but I wrote with a couple of others how to build a recovery-oriented system of care in your community. So I definitely have some resources that I'd be more than happy to share.
Doug, how about you? What are your ideas on resources?
I'll say that we're right now in the chain, in a wonderful point on this. HIMSS is doing some great things. Earlier in April, we started a new blog dealing broadly with healthcare IT issues, and there are pieces on it. I've got a submission in there now with my friends from Kaiser Permanente on one of the aspects of personal health records as well. So HIMSS has got some great new tools, as does HL7. We also see, my favorite blog is John Moore, our friend at Chilmark Research. People ask me what my opinion is. That's easy. It's what John said. And there are a couple of other places, certainly John Halemka and then Ligio Riccardi at the ONC. So the trick is this, however. For example, in our own work at Centerstone, we think we've adequately addressed all of the issues of security and privacy between the public site domain, the clinical piece, which is frankly the only part that's really clear, and a privately branded personal health record based on Microsoft's Health Vault. We've done a lot of work to batten that stuff down. We see some early precedents. What we'd really like is someone at the Office of Civil Rights to say, boy, do you ever have this right? Unfortunately, in the world, you can't get that kind of affirmative assurance. So what we can do is study and collaborate and make sure that they know what we're doing, which we have done. The resources are out there. If you want more, you have my email. I'd be glad to point you to other resources, other blogs, including my own, that collectively the resources are there. Now it's a time to move.
And Mike, I'll give you the last word on resources.
Great, thank you. And I guess for the resources I would put out there is the National Council has a Value in Technology program that we put together. So we have a number of consultants who know the field and we do suggest that if you get into this, and if you're not a technology person, it's not something you do alone. Bring someone in to help you move forward with it. So we have a cadre of consultants who know behavioral health and different technologies, and as well as some products and services that can help you get there. So for that, just contact me. My information is in there, but it's Mike L, M-I-K-E-L, at thenationalcouncil.org.
And we've forgotten NEHC.
Oh, that's all right.
We've forgotten NEHC. How can we forget NEHC from the contribution that's out there? The volume of work that NEHC is doing, and we're an honor to be a part of it. It's just the information is there, and we thank NEHC for your contribution, strong contribution to this critical time in our industry.
Thank you, Doug. Thanks, Doug. And with that, we'll need to bring the program to a close. So Linda, Doug, Mike, fantastic presentations. Thank you. And a great Q&A. So thanks, everyone, for joining us today. And when you do log out of the webinar, we will pop up a quick survey. So please take a moment and just fill that out. We do really appreciate your feedback. And we hope you will all join us on Thursday at 11:30 Eastern for the program on the governance request for information. So thanks, everyone, again, and have a great day.
Thank you, Kate.
Great. Thank you.
Thank you.